So good afternoon to all. We have a great pleasure today to have Professor Nedana with us from Germany. Professor Nedana is a professor of surgery and works as a director of hepatobiliary and pancreatic and transplant surgery and vice chairman at the Department of General, Visceral and Transplant Surgery at the University of Tübingen in Germany. In fact, from 1994 to 2009, till 1999, he completed his surgical training at the Department of General, Visceral and Transplant Surgery at the Hanover Medical School in Germany. And from 2000 till 2008, he worked as a consultant at the Department of General, Visceral and Transplant Surgery at the Essen Medical School, where he developed his skills in segmental liver transplantation and high-skilled hepatobiliary surgery. Then in June 2008, he moved to Tübingen in Germany. His main interest is segmental liver transplantation, mainly in pediatrics, and which leads to the development of complex hepatobiliary and pancreatic and transplant surgery. Examples, ALPS and living donors, Abult ALPS for non-resectable colorectal liver metastasis. He's a member of many different surgical and transplant societies, example ESOT, ELITA, TTS, DTG, HBPA. He's a reviewer of more than 20 surgical international journals. He authored and co-authored almost 200 publications with an H index of around 43. So we have the pleasure to have him today with us. Most welcome, Professor Nedana, with us. I guess we'll start with a case presentation who will be presented by our oncologist, Dr. Evie. It's a short presentation, then we'll go for the main presentation by Professor Nedana. The mic is yours, Evie.
Yes, so I'm going to start by a case presentation from the center. It's a female patient with only 29 years old who presented with stage 4 hepatic fracture, moderately differentiated adenocarcinoma with extensive liver mets. Her molecular profile is RAS wild type, HER2 negative, MMR proficient, and TRAC negative, tumor burden intermediate. So the patient started with FOLFOXIRI plus bevacizumab for 5 cycles here in Oman with good response. After that, the patient went to Germany, where she received FOLFOX6 plus bevacizumab from August to October 20, and beva was withheld due to anal fissure with a prolonged recovery time. After that, the patient was put on maintenance capecitabine for 4 cycles. And on CT scan from July 21, we saw that she has a disease progression in the liver. So as you can see in the images below, and lung nodule. After that, our team decided to go for FOLFOX plus cetuximab and in a second line, which she started on July 21. After some cycles, the patient presented with a severe allergic reaction to oxaliplatin. And on her CT scan from March 22, we saw that she had a partial response in the liver and stable disease in the lungs. Due to that allergic reaction, the patient was put on FOLFIRI plus cetuximab, which started on March 8th. And we took her case to our MDT discussion in March 13th, where we discussed about RFA in the lung nodule, followed by chemotherapy and resection of the primary colonic lesion, followed by intrahepatic chemotherapy infusion in preparation for liver transplant according to her clinical and radiological response. So here in the images below, you see the last PET scan that she has done recently, a week ago, and she underwent RFA in April 18th. So that's our case. Dr. Silvio, you can proceed with your presentation. I'll just stop sharing my screen.
So 1 second, I need to put a slide because according to your case, it's important to put a slide for where is it? I removed one slide, but I now decided to, after your case presentation. So, thank you again for this case presentation. Very interesting, very stimulating. And let's go with the presentation. Can you see me? Can you see the screen? Can you see my screen? Okay.
Yes.
Okay. So first of all, thank you to everybody for this kind invitation to talk about this challenging topic, which is liver transplantation for not resectable colorectal liver metastasis. Where are we sort of up to date or update about the situation? And we will see if it's only for non-resectable or not. Before starting, I'd like also to introduce myself, because thank you very much for the kind and nice introduction, but nobody knows where Tübingen, where am I actually? So Tübingen is a very small village, I would say, almost 80,000 inhabitants. It's nothing less than a small village with 30,000 students. So it's a university village. It's located in the south of Germany, near Stuttgart. Most of you know this area because of Porsche and Mercedes. But some of you performing surgery know because of the Erbe and Storz, where a lot of electromedical equipments are from. Just to let you, what does it mean living and working in Tübingen? On the right side, you see our small river with so this is the skyline from Tübingen, but it's a very old ancient university, born in 1477, almost 70 years older. 700 years old university. We have a lot of faculties: medicine, law, theology, religious studies, artificial intelligence, and Tübingen gave also produced 11 Nobel Prizes up to now. So small city, but a lot of work, mainly probably most of theoretical work. So let's come back to our topic, which is the situation. I don't know how is the situation in your country, in Oman, about colorectal carcinoma, but in Germany, it's at least a very important problem, being colorectal cancer representing the third cancer type in both male and female patients. That means it's a true problem we are facing almost every day. The problem is the colorectal metastases in these patients are already present from the real beginning, 2015 up to 25 of patients at the really, from the real beginning. And another 25–50% will develop liver metastasis within 3 years from the first diagnosis. And unfortunately, curative resection is possible in less than 25% of those patients with disease limited to the liver. And when the liver metastases are resected in the resectable patient, the overall survival, and please try, we should start from now to think about overall survival. It's important, overall survival as main goal is 30–40% in case of resectability, which is very low. But in case of patient with the stage 4 disease, like your patients, and with the modern therapy you can offer up to now, you showed some treatments, the modern chemotherapy and radiofrequency ablation, this and that. The life expectancy is less than 10%. Put all this concept in a figure, you can see this. So you can see that in case of resectable, you have a sort of a survival at 5 years around 40–50%. But for non-resectable, still being very low. So the question is, do we have some alternatives? May I ask you to mute some, because there are some noises in background.
May I ask the audience please to mute their phones?
Thank you. Sorry, but it's quite difficult because there are many noises also behind me. So do we have any alternative to this modern strategy, chemotherapy, local or systemic therapy? As far as I know, no, unless the only potential alternative is a liver transplantation. But before starting to talk about liver transplantation, just in general, oh, we have a liver transplantation, let's go for it. We should keep in mind which are the goals of liver transplantation in general. This is a survival curve of patients undergoing liver transplantation, Eurotransplant area, where do we live and work. And so just making a curve, overall survival for any kind of liver transplantation at 5 years is around 65%, which is personally I find very poor, but this is the data, official data from Eurotransplant. In terms of transplant oncology, you see that in patients undergoing liver transplantation, for example, for hepatocellular carcinoma or liver metastasis of neuroendocrine tumor, the results are quite similar. So the goal should be overall survival around 65–70% at 5 years. This should be our goal. What does it mean, unresectable colorectal metastasis? This is the very recent paper from an International Hepatobiliary Pancreatic Association published in Lancet very recently. The definition is very clear. Metastasis present at diagnosis or after previous resection, which cannot be resected with curative intent, either by standard or complex or combination of different resections techniques. This is the definition of unresectable procedure. The history of liver transplantation for colorectal liver metastasis is relatively old. It's almost 20 years old. And we can go, you can summarize in this graphic very simple. We can distinguish two eras, before 2000 and after 2000. Before 2000, there were only center just trying to put some cases together. This is just the registry paper from ELTR 1995. And after 2000, the experience from Norway. What you can see that overall survival at 5 years in the first era was very poor, far away from our goal being around 60–70%. After 2000, the results suddenly improved significantly, definitely better, but at one price, a high recurrence rate, no difference in the first era and no difference in the second era, even somehow worse or similar. What's happened actually? It was, I would say, I would like to define this change, the Norwegian revolution, because the Norwegian friends and colleagues provided all this data recently in many publications during the last 10 years. From the SECA-1 paper or the study published from the Oslo colleagues, we can see the graphical demonstration of the true benefit of liver transplantation. Putting the curve we've seen before for patients with the non-resectable colorectal metastasis undergoing standard chemotherapy or any therapy, and patients with undergoing liver transplantation, usually selected patients, we can afford overall survival rate around 65% after 5 years, which means very good results and a so-called transplant benefit of 50%, which no other alternative therapy can offer for this kind of patients. But what we have learned from the SECA-1 and also from the SECA-2 study from Oslo is the selection of patients is the most important thing. And from the SECA-1 study, we learned that the first selection criteria are the Oslo criteria expressed here in form of negative prognostic factors, which means the maximal tumor diameter at transplantation bigger than 5.5 centimeters, pre-transplant CEA values greater than 80, progression under chemotherapy, time interval diagnosis to transplantation shorter than 2 years, and the summary score is going from 0 to 4. What does it mean? In patients with the 4 factors, the results are very poor, but you have at least 2 or 3 factors at 5 years are good, and more than good, I would say excellent for patients with just one of the here mentioned factors. In addition to that, the colleagues from Oslo performed the SECA-2 trial, which is experimental arm, transplantation versus resection, transplantation for non-resectable patients with metastasis disease, or transplantation for non-resectable with synchronous disease. But what we have learned from D, and there was a third arm D, using marginal livers, but I will talk about that in very few slides. So what we have learned from this topic is observe the Oslo criteria. Be sure that you have liver-only disease, for example, using PET-CT scan telling you about it. Third, be sure that you have a patient in good performance status. Fourth, exclude aggressive tumor biology. What does it mean? Consider the FONG clinical risk score, which a very old score telling you about the recurrence of disease after liver resection. It's a score published in the mid of the 90s. One of the most important parameters, the metabolic tumor volume at FDG PET-CT scan. Another important marker of tumor biology is the localization of the primary tumor. So keep in consideration your case, right versus left colon, being the right, the prognostic worst one. Consider the BRAF mutation versus wild type, and consider also the tumor burden score. Making a sum, put all the things together, you can see here the results. If you have Oslo score between 0 and 2 versus 3 and 4, you have these overall survival rates. I'd say very good. But this is very fancy, very challenging. If the metabolic tumor volume seems to play the most important role, if you have metabolic tumor volume, global volume of at the last PET-CT scan you have seen lower than 70 cubic centimeter, the results could be wonderful. And if the FONG clinical risk score is very low, you have excellent results. So selection of patient, and coming back to your patient, which if I correctly understood, was a right located colon cancer. You see, if you transplant patient with right or left tumor, being right in terms of overall survival, poor or poorer than the left. Putting all things together and summarizing all these selection criteria in here, which are listed in this figure, what does it mean? Does it mean that if you select all these patients, you start, for example, with 100 patients coming tomorrow to your center in Oman and say, oh, I have a unresectable colorectal metastasis. If you apply this selection criteria, you will have probably less than 5% of patients which are candidates for a liver transplantation. This is a very important measure you should keep in mind. Don't be frustrated, because we have this experience. We have published the first paper, and then a lot of patients ask. But at the end, less than 5% of patients are the only one who really benefit from a liver transplantation. And one big error you should avoid from really beginning, suggested from the Compagnon Hepatobiliaire, who showed recently a compassionate use of liver transplantation should be avoided because it's usually associated with poor outcome. So think about the girl, the young lady you're talking about. Go in your mind back, think which is selection through selection, which is compassion, and try to find the right decision about this case. So, in other words, which is the actual status of transplant oncology for colorectal metastasis? We can see here from the very recent published results from the group from Oslo, we can in setting of disease donor transplantation. Sorry, I have to go back. In setting of disease donor transplantation, we can a full-size liver transplantation. We can offer results who are similar to standard indication, or in selected cases, even better than standard indication. And this is true in disease donor liver transplantation. And very recently, the North American group showed that this is also the case if you perform living donor liver transplantation. These are the first 10 cases worldwide published of standard living donor liver transplantation for colorectal liver metastasis. The price, the cost of this procedure, again, we were talking about overall survival. It's unfortunately a very early recurrence of tumor, and usually, in contrast to standard resection and hepatectomy, that is outside of the liver. You see, liver recurrence is very rare in contrast to hepatectomy, but very often outside and mainly located in the lungs. But if you can treat the lung metastasis or the extrahepatic tumor recurrence aggressively with any method you have at disposal, then you can also have excellent.
Therefore, based on the
you can have also results. So there is a mistake here, sorry. And in this slide, you can see that in summary, we can talk about with excellent overall survival and treating the recurrence, we can say, probably we can talk about liver transplantation in terms of curative treatment for this kind of patient.
Therefore,
and this is been recognized by ILTS community already 2019 at the consensus conference, and very recently from the IHBP Association, providing the guidelines for liver transplantation for non-resectable colorectal liver metastasis. I suggest to go through this important paper. We give the recommendation with strength of recommendation for any kind of approach from the indication, selection, and the patient, and so on. The other question is, should we consider liver transplantation? I want to be a bit provocative, only for unresectable? There is a patient, or there is an option for resectable patients too. Again, the colleagues from Oslo tried to compare patients undergoing liver resections versus patients undergoing liver transplantation by comparing them according to the metabolic tumor volume. And if we put patients with, let's say, very advanced disease, but with moderate metabolic tumor volume, which is the same we should use for the selection, we have excellent results with overall survival at 5 years, 39% for resection versus 83% in liver transplant group, considering also the fact that patients undergoing liver transplantation have a higher tumor burden score and a number of liver metastases, and so, I mean, it seems in selected patients, it'd be great also, instead of performing resection, also to perform liver transplantation. And to be more provocative, this is a very interesting paper published in cooperation between Padova Center and the Oslo Center. They put together patients with high tumor burden score within Oslo criteria, and they showed this. If you put patients with high tumor burden score and low Oslo score, the results of liver transplantation were definitely better than the results of liver resection. So therefore, consider this case. And this the confirmation that we are talking about real facts, this is very recent, again, paper in JAMA Surgery, where they compare patients undergoing portal vein embolization and liver resection versus similar patients undergoing liver transplantation for left-sided tumor. And you see that in this case, the advantage is for the transplantation. Therefore, if you are considered patient with undergoing ALPS or two-stage hepatectomy with high tumor burden score, you're sure you have a very early recurrence. A paper published also with our group in Annals of Surgery 2 years ago, very high recurrence rates in the liver within a short time with high, so with very, very poor survival rates. So think about also this provocative indication, not only for resectable, but let's say for marginal resectable colorectal metastasis. So therefore, once we have stated that liver transplantation can play a role with this, for this kind of patient, the question is which kind of grafts should be offered to this patient? Should we use deceased donors, standard or ECD1, or living donor, standard or living donor rapid? And then the decision, according to the recent guidelines, should be dependent by the kind of grafts you have and the local rules you have to your country. And if you apply living donor transplantation, should be care that so maximal safety of the donor should be guaranteed. What about standard disease donor? In standard disease donor transplantation, we have a problem of organ paucity and a big competition between centers, between different kind of indication. But from an ethical point of view, one might argue that patients with similar expected overall survival should have the same access regardless the primary diagnosis. So therefore, my question is, considering the fact that the colorectal metastases have excellent results, the question is, why not give them an access to standard disease donor allocation? Which graft should be offered, therefore, to this patient? Unfortunately, because of competition with standard indication in terms of organ paucity, at least in Germany, is not possible. And because it's still experimental, not validated through randomized prospective studies, and therefore, we should go for alternatives. Sorry, there's something with the computer going faster than I do. And consider the opportunity to consider, instead of standard indication, to use ECD donor or living donor transplantation as a potential source of graft. This is also what the recent guidelines propose, that it seems that the patient affected of colorectal metastasis could benefit from using of ECD donors. But again, the colleagues from Oslo, who in the SECA arm study, the SECA arm group D study, showed the results using marginal livers are not that good. So the conclusion is the preliminary study, the preliminary results from Oslo say, be very aware using marginal grafts from deceased donor or DCD donor for this kind of patient. So the question is, does living donor liver transplantation represent a potential alternative to this indication? Yes, it seems to represent alternative, and also stated by the recent guidelines from the IHBP Society.
Hernandez Alejandro et al. Has very recently demonstrated that it is possible to perform living donor transplantation for colorectal liver metastasis using standard grafts, in this case 8 right lobes and 2 left lobes, with excellent results.
But the problem is, if you use a standard liver grafts, mainly right grafts, the major problem is to have a danger for the donor, where the bigger the graft, higher are the risks taken by the donor. So the question is, again, in terms of living donor liver transplantation, we should consider the true benefit and risk taken by the donor for this kind of procedure. Is it justified in setting of, let's say, a sort of experimental procedure? And mainly the donor risks and burdens should be perceived, as a complex assortment of potential physical, fatal risk, social and psychological outcomes, psychological outcomes. Therefore, it's very important when you go for living donor transplantation for this kind of patient, you should educate donor and recipient on the natural history of the surgical treatment of colorectal metastasis, including the expected high probability of extrahepatic recurrence. What does it mean? When I talk to my patients, they are full of hope, a lot of expectancy, giving you, so you will save my life and everybody will be happy. No, you have to inform accurately what's going on. You have to tell us good results, but with high risk of tumor recurrence, even in a shortened time. If you inform these people, they will be happy too, but they're more informed and they will have less psychological and social stress. So, do we have any alternative to standard liver transplantation in terms of deceased donor and standard living donor liver transplantation? Recently, we have a sort of renaissance in this context of auxiliary liver transplantation, which is introduced again by the colleagues from Oslo with the rapid concept. What does it mean? Resection and partial liver segment 2 and 3 transplantation with delayed total hepatectomy. What does it mean exactly? It means the rapid technique, renamed living donor rapid by our group, LD8 APT from a Belgian group, or Aspire from their group from Regensburg, is nothing else than an auxiliary liver transplantation using small, usually left or left lateral grafts with a graft body weight ratio definitely less than 0.5 from deceased donor or living donor with or without portal inflow modulation, with delayed removal of the remnant right native liver in a second step. Let's say a sort of combination of Appold and Alps procedure. I will show immediately how does it work. But again, in standard situation, using rest grafts from split grafts, we have lack of transplanted organs. If we take away left lateral grafts from deceased donor for colorectal metastasis, it would mean probably to take away chance of liver transplantation to a child or a small recipient. And one additional problem is to plan this procedure in patients undergoing chemotherapy till last minute before transplantation. So very important logistic problem as chemotherapy scheduling. So which alternative do we have in terms of organ parasitic? Probably make a sort of a combination of standard, this is Professor Line from Oslo, that's me, and combining both procedure in form of living donor Appold Alps or living donor rapid. Again, the main topic is in this context to maximize the safety of the risk taken by the donor in experimental setting, maximize the safety of physical and psychological and social. The living donor rapid has been described in different papers from our group and the group from Jena. And up to now, worldwide, mainly, and I would say only in European countries, 20 living donor rapid procedure for colorectal metastasis have been performed up to now. This procedure has been also recognized from the HBP consensus guidelines, but as I will show you in the next slides, it's very technical, challenging operation. So you start first performing explorative laparotomy of the recipient, excluding peritoneal carcinosis and lymph node metastasis. And it's important this to know, because many people do not consider the lymph node metastasis at the liver hilum. This should be negative. We already had a dropout of 3 patients, because although the PET-CT scan was negative, at the end, at the exploration, they had lymph node metastasis, which would have compromised the outcome of the procedure. So, start not with the donor recipients contemporaneous, but start with the recipient first of all. Excuse me, I have to close the window because the helicopter is starting now. So then once you have performed the explorative laparotomy, you perform a left, not the left lateral, but the left hepatectomy included segment 4. And this is a wrong picture, but you should remove segment 1, 2 to provide more space for the left lateral graft, and use the common cuff of the middle hepatic vein and the left hepatic vein. And then once you have done this, you implant the graft, usually a left lateral lobe, from the living donor. In this case, you perform first the first the liver vein anastomosis using the common cuff, not like in this figure. Then you perform the portal vein anastomosis, end to end, left to left, or left to main portal vein, or the end to side, according to the strategy, the anatomy, or the portal flows. You perform then the hepatic artery, also in this end to end or end to side, with or without interposition graft, using different grafts, vascular you can use. And you see here, you can ligate the right portal vein according the concept of ALPS procedure to push the liver augmentation of the future liver remnant. Then you perform the biliary anastomosis. At the first step, you perform a biliodigestive anastomosis or duct-to-duct anastomosis, which is usually performed by the colleagues from Jena. We did once. I wouldn't do anymore, so I just go for that.
In context of...
So I would suggest to perform this. The next slide, I will let it run because there was something went wrong with this with the slides here. But listen, the message is important for the technical point of view regarding inflow modulation.
But in context of portal vein anastomosis, as reported in historical papers, in setting of auxiliary liver transplantation, there is a continuous reciprocal still phenomenon of portal venous flow, which may influence the regeneration of small liver grafts. In non-cirrhotic settings, based on accurate intraoperative measurement of portal vein pressure and portal vein flow, we can distinguish two different scenarios and act consequently. In non-cirrhotic normotensive setting like colorectal liver metastasis, the resistance to portal flow in the native liver is less than that in the transplanted graft after.
So I'm very sorry, something went wrong. So again, it's important you consider the portal flow and the portal flow modulation, because you may have an overflow and going in small for size syndrome like we have for standard liver donor transplantation, or you have hypoflow, and then you have, therefore it's important you measure it's important we measure intraoperative the portal venous flow, the portal venous pressure, and the gradient. So using hemodynamic measurement in this kind of transplantation is fundamental to avoid terrible complication, losing the graft or losing the patient because still phenomenon of portal flow between the two liver parts.
In non-cirrhotic.
Therefore, according to the results you get, you will react according to the findings you will have. And there you can provide in making graft inflow modulation according to different techniques. I suggest to read the very recent paper from the Azoulay group, or as we usually do, we close the right portal vein to induce a compensatory hypertrophy of the future liver remnant. Once you have finished the first part, you have to monitor the interface, during the interface, and mainly monitor the function and not only the volume of the remnant liver. And you can do this by using a HIDA scintigraphy, famous in ALPS, but the Oslo group proposed, and which is very good, a sort of microdialysis catheter, which works very well. You put on the liver surface and it will tell you how is going the liver function. This is this comes from neurosurgical operation, and it seems to be very reliable. So monitor not only the volume, but also the function. Once the liver is regenerated from function and volume, and usually within 2 weeks is the case, you bring the patient in the OR, remove the remnant part of the liver, and that's it. The colleagues in Belgium performed this kind of operation in two cases, even laparoscopically, the second part of the procedure, removing of the native liver. Which is the situation right now? We are, so as I told you, 20 living donor liver transplantation according to the rapid technique have been performed. So 10 cases performed in form living donor standard, and more than 56, around 56 cases have been performed in Oslo. Would be curious what Professor Panaro was telling us, giving probably a short update about the TransMed study. These are the actual running studies, SECA-2, SECA-3, TransMed going running in France, the COLT study in Italy, Soulmate and Rapid. They're based on deceased donor liver transplantation standard, and living donor liver transplantation, there is only the Toronto protocol and the liver to heal studies here in Germany, in Tübingen and in Jena. In case you want to go through these topics again, this is the literature I would suggest to go through. And in summary, we can state following. Liver transplantation for unresectable colorectal metastasis can provide long-term results similar to other standardized oncological indication in highly selected recipients. Liver transplantation can be offered also to patients with resectable tumors with high tumor burden score but low metabolic tumor volume. But due to organ paucity and missing prospective trials, we are forced to resort to alternative sources of liver grafts. And living donor is a valid option too, in form of standard liver transplantation or living donor rapid, which is the last one, a technical demanding, and the measurement and modulation of hemodynamics is mandatory. But again, in living donor setting, the ethical, psychological, and social aspect should be seriously considered. Sorry again for the technical problems. I would not expect this, but thank you for your attention. In case you have some question, you can mail me or call me whenever you want.
Thank you, Silvio. It was very clear. We have a good audience. We have also international experts. From Spain, we have Alejandro Serrablo.
Hello, Alejandro.
We have also the colleague from Oslo, Magnus.
Oh, Professor Magnus.
Buongiorno, Silvio.
Buongiorno.
From US, Chicago, and from Milan too. I don't know the other guy, but
we have from other Gulf countries as well.
Yes. Go ahead, Abdalat, if we have some questions.
Thank you, Professor Nadala, for just, really comprehensive and interesting topic. A lot of, I would say, questions in mind, and a lot of maybe challenging cases going on with such topic. I will keep maybe the door open for the audience if anybody have any questions, and then we'll go for maybe some discussion.
So Tamer
Yes.
Al-Madi.
Yes, Dr. Tamer.
Yes, thank you very much. And thank you for you, Professor Nadalin, for this nice presentation. I'm Dr. Thamer Al-Ghamdi from Saudi Arabia, hepatobiliary surgeon. My question, is there any rule for the synchronous and metachronous colorectal liver metastasis in the indication of the liver transplantation?
So first of all, thank you very much for this very important question. If you go to the Oslo indication, so to the Oslo score, you see the one major parameter is at least 2 years between diagnosis and transplantation. And diagnosis of metastasis or diagnosis of the first tumor. So indeed, what they say in between the lines is that metachronous metastases do better than the synchronous. But usually, this is at least our experience, most of the cases, more than 90% are synchronous metastases. So therefore, it's important, I stress again, it's important that you not only remove the primary and then going faster for the liver transplantation, but keep the patient stable under chemotherapy for the longest time you can keep the patient. If you have stability, at least 6 months or even longer, that will be the best candidate for liver transplantation, according to the other selection criteria you can have.
Thank you, Professor Nadalin. But also the other question,
Yes.
Is there any difference between the rectal metastasis and colon metastasis? You know, the rectum is located in the pelvis and surrounded by many structures, and there are also guidelines and international protocols to treat these patients, starting by neoadjuvant radiochemotherapy, or there are many regimens to treat these patients. Is there any rules or different rules between the rectal and colon liver metastasis?
Excellent question again. I think no, let's say rectum versus colon, but yes, in case left versus right. This is clearly demonstrated, and we see every day for standard indication. You see patient, we have seen also today in our multidisciplinary tumor board, young patient with the right colon metastasis doing bad results after liver resection. So whatever you do, the tumor biology is more aggressive. The rectum, okay, we consider rectum maybe wrong, but we consider belonging in this context as a left colon, and we suggest to perform neoadjuvant treatment, remove the primary, perform standard palliative or adjuvant therapy, preparing the patient for the liver transplantation. Hope it could.
Yeah, thank you very much.
Silvio, I am, this is Alejandro Serrano from Spain. Yes. Silvio, I have two questions maybe. One of them is in the bilobal liver tumors, you know, maybe a liver metastasis, bilobal liver metastasis, there is 80%, 83% of recurrence in this case. How is your criteria in disappear liver mets when you included this patient in nonresectable previously neoadjuvant or chemotherapy or adjuvant chemotherapy, and you get a good response by chemotherapy? You keep the liver transplant indication or move the patient to liver resection?
This is a typical question I would usually ask because it's very difficult.
Paldak, Linus usually said, go ahead with the transplant.
The question you don't want to get, so it's very difficult because we are talking about missing metastasis, and you see so disappearing, and then you go for liver transplantation. To be honest, you must be, you know, the history will be, they will come again, sooner or later, unless you keep the patient long life, they disappear temporarily. But if you check the curve, going down in any case. So if stage 4 once, I think stage 4 forever. So there probably you must be courageous and go for liver transplantation. Fortunately or unfortunately, we didn't have this missing metastasis. So in that case, we didn't see anything because it would be very difficult to go for liver transplantation. You're right, but it's
well, but I think that the good response, maybe you can rest the patient is going well after liver transplant because it's biologically it's a good candidate to do that. In the other hand, is how you decided rapid procedure, living donor transplant, or this is the transplant in colorectal liver donor. What is your candidate, ideal candidate in these three settings? Rapid, living donor, or disease in colorectal, unresectable colorectal liver mets?
So if I would live in a country like Norway, when I have livers everywhere, just here around the corner, open a box and
in Spain too, in Spain too.
In Spain too, I would go only for disease donor liver transplantation full size, because one-step procedure, no portal hypertension. It's really very easy, straightforward operation, unless they have a complication because of the primary tumor. So if you have this source, go for this. ECD donors are not, seems not to work that well, but you can try it. You have these extended and extended donors. If I could decide who, I personally would suggest a standard living donor, a beta left, and as a last procedure, the rapid, because really it's technically very, very demanding. You need a huge experience performing microscopic anastomosis. You need a huge of experience in pediatric liver transplantation performing in very small babies, because the artery is around 2 millimeters. You don't sleep very well the first week because of just going there. So in the order, go for standard disease donor. If you have some super selective ECD, standard living donor, and then rapid, but not the other way around. We are forced to use living donor rapid because the procedure is still considered experimental, and for the maximal, ultra maximal safety of the donor, we must do that.
Totally agree. Amazing lecture as usual with Silvio. Grazie mille.
Right.
Dr. Abdullah, can I ask a question? Hello?
Hello?
Yes, I want to ask a question about this group, subgroup, which is MSI high, where we utilize immunotherapy currently. Any experience with immunotherapy and liver transplantation? That's the first question. The second question, patients with limited extrahepatic metastasis, which can be resected or ablated, is that an absolute contraindication for liver transplantation?
Again, tough question. I like you guys very much. So, talking about immune therapy in the liver transplantation setting, it's a very modern actual topic. So, first of all, we do not have any experience at the moment in patients undergoing immune therapy for usually hepatocellular carcinoma and undergoing liver transplantation. Probably Fabrizio can add something about that. There's a lot of activity on this topic, and I can tell you that in the next November, ESO, European Society of Organ Transplantation, is going to make a consensus conference on this topic, immune therapy for standard oncological liver transplantation. And because it's very tricky, because you have to find the right moment when to stop the immune therapy, because unless you're going to risk to lose the graft. The other question is to use immune therapy after the transplantation. And I have no experience personally, but in Germany, we wrote recently a paper about this regard, not in setting of colorectal metastasis, but in setting of hepatocellular carcinoma in terms of recurrence. And it's very dangerous game. The risk to lose the transplant because of immunotherapy is very high. So you have to balance both things. So I would not suggest to use immune therapy after. You can use before. But again, probably going back to the question to Alejandro, this is one of the major disadvantages of using deceased donor liver transplantation. You get the liver when it comes, but you can plan this unless you have different rules, Fabrizio, in the transplant study. Therefore, if you have a patient undergoing immune therapy, which is very good, probably, I don't know yet, but then you got the liver, while you do home, what should I do? Should I play this game and risk the loss of the graft because hyperacute rejection? I don't know. But it's very actual topic, and probably we will have more answer very soon.
Thank you.
And there was a second question now regarding the limited extrahepatic.
Yeah, true, yes.
Oh yeah, exactly. Sorry, I forgot. The second question is the extra part. So, the group from Oslo, they have, I don't know how many patients, they have very few. So again, we are talking about 56 patients up to now from Oslo, and they have less than, I don't know, probably should, that Magnus should comment on this, if I'm allowed to. You have the experience, but Paul Dag usually presents some cases with isolated lung metastasis undergoing control for a long time. And they did few cases. Magnus, am I right? If he's online, if he's not online. Dr. Magnus? No. So They were very few selective. A small metastasis, like probably your patient you showed, but they will come back again. So what I do in your case, it'd be interesting to go back after the question, to go back to your patient, what I would do with your patient, we should do, what we should not do. But probably I would consider also to remove the lung metastasis, check the patient under for sometimes if it's stable, then probably go for transplantation. But these patients have other problems, in my opinion.
Yeah. This was the decision, in fact, to go for thermoablation of the lung nodules. Just a question. Sorry, Prof. Mansour, you want to say something?
No, I just want to say thank you. Thank you very much.
Just a question regarding the timing of removing the primary, and I may ask maybe Dr. Hamed Al-Adawi, who's a colorectal surgeon, to comment on that from his point of view as well. I don't know, what do you think, Professor Nadala, regarding removing the primary? Is there any specific timing for that?
No, you have, so this is the classical situation. Today, no patient came, but last week came. Every week I get 1 or 2 patients with this diagnosis. They come usually synchronous metastasis, and they get a lot of hope, and they say, oh, what to do? And you first of all select the patient, try to make the history, the location of the primary, blah, blah, blah. You use these selections criteria. Then you tell them which is the story, the clinical natural history, what you can do. And then once you have a patient who is stable under standard chemotherapy, then you remove the primary tumor, independent from all. But once you must be sure that in case you are going for a living donor, you need a donor. If not, it doesn't make any sense to remove the primary, which usually almost disappear. If you have a deceased donor, you must be sure the patient, the candidate is transplantable. Therefore, you should be tumor staging, screening, or lung, whatever. And if the patient is transplantable, then you remove the primary, you prepare. But I always say, forgive temporaneously, you have the option of a liver transplantation, and then treat the patient like the patient who would not have any colorectal metastasis. I mean, consider him like primary tumor, remove, make adjuvant therapy, but constant focus on the liver. And if he's stable, transplant.
Thank you, Silvio. In France, the preliminary result of TransMed trial are so good. So the national agency decide to include this kind of indication as a standard indication. So starting from November, if we have some cases, we just present the cases. There is a special commission in Paris, and after the decision, we just give some. We have a different. We had a prioritization of the liver in France, so we give some point to this kind of indication. So we try to do a liver transplantation in 2 weeks after the indication. So we could decide if we need to stop the immunotherapy or the standard chemotherapy or continue. So we could decide if this kind of indication, this kind of surgery. Yes.
Fabrizio, you are telling us that the results are very excellent, which I believe really, and it shows again how France is more advanced than other European countries. Germany is very, very, very conservative. To change something, it takes a long time. Where are these results? Are going to be published soon? How many cases you have now? So in France, when do we see the results?
You have 70 cases in the protocol. But we included more than 20 cases behind the protocol. So we have almost 100 cases transplants. So but the results are quite the same. The standard indication for ACC or alcoholic cirrhosis. Yes.
I totally agree. I totally agree.
Yeah. So for is the first time this National Agency of Biomedicine decide to do this kind of indications, like in this case. So if we have if each center in France have a patient, is we just with the Zoom like today we present the case. There is a special commission, and we decide to include the patient on the waiting list, and we give some point to this patient to do the liver transplantation into 2 weeks if we can. But normally in France we have 4 or 5 donors a day, so normally we could do a liver transplantation to 2 or 3 weeks.
It's fantastic.
Yes, I think the preliminary results are better than the ACC that were downstaged. So I think is the new standard indication for a liver transplantation. If we have a whole liver, as you said, it's better. But I think your proposition, so rapid study and living donor, may be a solution, especially for in some country that they don't have a cadaveric donor, as in Oman or Saudi Arabia, or in this kind of country.
Yes.
Thank you very much, Silvio. It was a great exposure.
Thank you. Probably we can conclude going back to your clinical case, if you want, and we can discuss again. So what? So also Fabrizio, which is your opinion, to ask the other what they would do. What do you think? Should we see the slides again?
Perfect. I'm going to share the screen again. So here's the first slide.
May I comment?
Yeah, of course.
So first of all, you see here is 29 years old. This is the first thing you see. A young patient coming in your outpatient clinic, and your heart fluttering, oh, the poor girl. And then you started, first of all, with compassion, then all of the family behind. And so then you first comment, be aware of this. Start from the real beginning to be rational and not emotional. The second comment I can do here is, do you mean the hepatic flexure of a right colon? And the right colon, you have seen the results from Oslo. Fabrizio, which is your opinion about right colon?
And in the literature, we know that right and left colon, the result also for just a surgical resection of the liver metastasis are quite different. So the right colon, we have a bad prognostic. So, but I don't know if we have a molecular profile, wild type. Yes. 29 years old and wild type. But we need, I think we need, as you said, in this case, we have a suspicion of 2 or 3, I don't remember, lung metastasis, very small. I think the first step is try to treat this kind of localization with maybe microwave or thermoablation, and wait the chemotherapy and see if the patient had the recurrence, will have a recurrence or not. I think
if you can stay on this slide, what I miss is, for example, so if it would be my patient coming in my outpatient clinic. So first of all, it's young, right colon. Again, it was not clear enough. Interesting, you have RAS mutation, wild type, which is good, but interesting. And this is one standard question as to POLDAC. Why they always put BRAF mutation? And it seems that although in liver resection setting, KRAS seems to play a very important role, which I'm sure 100%, it seems not playing an important role in colorectal metastasis. So what I would ask the pathologist, give us information about BRAF. The other question is, what about the tumor marker from the really beginning? Was it? And
Yeah, 48.
No, the
48.
tumor marker on presentation, the tumor marker was massively elevated.
Yes, but it's important.
It was
tumor biology.
It was in
What
thousands. Yeah.
Exactly.
The presentation was very aggressive. The tumor was occupying most of her abdomen. That's happened after pregnancy. Yes. And that's the reason we utilized FOLFOX-IRI, and she had excellent response. She's BRAF wild type.
Wild type.
MSR proficient.
Proficient. And CEA from baseline, it was 24.
And no IV. Her CEA was highly elevated in thousands.
And what we have also learned, if I can give you some, so it's very nice case, interesting. We also measure CA19-9, which is usually for pancreas, but mainly in and what we see usually CA going down and CA19-9 being up, which is, in my personal opinion, a poor prognostic parameter, but it's not published. So
I'm sorry, I don't have CA19-9. I don't think we looked at it. No.
No, it's just as a proposal, suggestion. So based on our experience, and not so we are just discussing. So the next slide.
In our protocol in France, we use also RAF.
BRAF, yes, exactly.
Yeah,
exactly. Yes. This is what the message is: selection of patient. Remember the selections criteria. So one question, was the primary tumor not removed at the beginning? You started immediately with chemotherapy.
Yeah, her main symptoms were related to the liver, and the liver was massively enlarged and very painful. And she was not obstructing. Strangely, she was not obstructing.
I totally agree. And then, as Fabrizio said, regarding this metastasis, lung metastasis, again, she's very young. I would try everything, but probably if it's the only one, I would remove this. Of course, chemotherapy, if it stays, remove and check along the time. And fish is stable, remove the primary, and then probably transplant her. Can we see the next one?
Sure, after the chemo.
She had an excellent response once we introduced cetuximab, in addition to the FOLFOX and FOLFIRI afterwards. Especially in the liver, the CT of the liver displays a very good response.
And here the last PET-CT.
The PET-CT shows an active tumor.
Yeah.
Yes.
How big is it?
The biggest lesion is described as 7 centimeters.
And how huge is the metabolic tumor volume? How many cubic centimeters?
I guess we don't have that information.
Yeah, I know. You should ask the radiologist, because also our radiologists do. What's this metabolic tumor volume? They don't have no clue. Then you go with the papers. First paper, second paper, third paper from also. They will compute it. So, but again, you have 7 centimeter bigger tumor, probably more than 70 cubic centimeters, 73,
Probably.
I mean, but you have a right colon. You can again check BRAF and put all the things together. Unfortunately, we do not have yet any score calculator, but you tell the patient, okay, if we perform a liver transplantation, the curves are going this direction, and the other direction. And then if you have a living donor, you must talk honestly to the family. And if they say, okay, I put everything in order to get a liver transplantation with excellent success, even 2 years is okay. But then remove the primary and consider also the FONG clinical score before going for liver transplant. This is what I do. This is my personal goal. Fabrizio, what do you think?
I agree with you. I would like to be aggressive because it's a 29 years old girl, and she has a long history. Finally, I think we need to try to do everything. So the thermoablation of the lung metastasis, chemotherapy, to have all the items that you evocated. So the marker CA19 and BRAF, and if we don't have a progression during this interval of time, the ablation of the primary tumor, and discuss for the rapid protocol with the living donor.
Professor Nadella, what do you think about the intrahepatic chemotherapy infusion?
If you are a member of HBP Society, I would suggest to go to the records of the meeting. It was like the actual war, Ukraine against Russia. There was a really war, I've been told. Fabrizio, you were there, but the friends of me, they told me it was so. It seems to work, but it works only in US, and mainly it works most than everywhere in New York. And in my opinion, with what is not reproducible doesn't work. This is my personal opinion. Second, some of center use intrahepatic or the intraarterial local chemotherapy with good results, but against at the end, the story will be this as a bridge into liver transplantation. And one of the major messages I got from New York, don't do that if you're going for liver transplantation, because the artery and even the portal vein, due to inflammatory reaction, will be a mess. And if you're going even to do a living donor, it doesn't work. So it's a potential solution. Therefore, I would, for example, consider this for this patient in case I would not go for liver transplantation.
Today we have another problem because it's difficult to find the catheter. So in France, we stopped this procedure because we don't have the catheter. So we have a good radiologist that try to do embolization of the gastroduodenal artery, the pyloric artery before to insert the catheter, but the problem is to find the catheter. And for the metastasis that finally we perform a surgical resection, I think there is no difference between the systemic chemotherapy and the intrahepatic chemotherapy. So I'm not sure that intrahepatic chemotherapy is very effective for this kind of cases, especially if we decide to perform a liver transplantation and living donor with a small artery. I think it's better to continue the systemic chemotherapy. Yeah, yes.
Okay. Another question regarding the periportal lymph node. If they were, for example, positive in PET scan, would that change a lot? I mean, in the management? Or?
Don't do it. I mean, the lymph nodes are the liver hilum, not the lymph nodes of the primary tumor.
The lymph nodes, the periportal lymph nodes, they were, for example, positive. They got a response with the chemo, but
it's a contraindication, at least at our center, and this is also what the POLDAC suggests. So therefore, it's very important. Mainly, so whatever liver transplantation we perform, disease or living donor, avoiding if in living donor, avoiding the operation to the donor, start always the exploration of the abdomen, because the PET-CT, this is what we have learned. For example, they don't see the lymph node metastasis quite often. Not only the peritoneal carcinomas, but the lymph node metastasis. And this is could be dangerous, because I know some cases from other centers, they ignored this and the recurrence was immediately there. Because you are patient under immunosuppression, not immune stimulation.
okay.
Okay, I think we must finish.
We are done. More than one coffee. Water.
Yeah.
Thank you very much, Dr. Nadala. I think
it was very nice to talk to you. Thank you very much for the invitation. Thank you, Fabrizio. Thank you to the whole audience.
We took a lot from your time, your break time. Thank you.
Thank you.
See you
maybe in Oman.
Hope to see you there. My pleasure. Bye-bye.
Okay, bye. Thank you, Abdallah, for the wonderful organization.
Thank you, Fabrizio.
Thank you. Bye-bye.